the Director of Comprehensive Care Service. I don't know what exactly it's called nowadays, Roy.
It's still that, yeah.
Still that, okay.
Like a focus group that, patients decided on the title. It underwent so many, as you know, you started some of the earliest acronyms for this service.
That's right. That's right. Yeah. I'm glad that all those acronyms still survive, including STEP.
Yeah.
So Roy is an expert in several aspects of psychiatry, but in particular psychopharmacology, and he has many contributions in the field to his credit. And he's also an important part of the SMI advisor. Some of you have heard Rob Coates recently speak to our group on SMI advisor, what all it can offer and so on. Roy is one of the key members of that group as well, who has been contributing. And I thought that getting Roy in our group sometime in this kind of an informal session would be a good thing to tap into his enormous experience in various aspects of schizophrenia psychopharmacology. And Roy, as I have mentioned to you before, this is a group that we informally meet about once a month to discuss different aspects of psychopharmacology as it applies to early course psychosis. And all the people on this group are prescribers. And so we keep it interactive. And, we typically focus on one topic, but that will not be the only topic. We discuss that as a starter, and then maybe everyone can chip in with any other pharmacological challenges they're experiencing or any issues that they want to bring and so on. So the topic I thought of for today is something that stems from my own clinical experience, and which I'm sure many of you will resonate. And also, I know that Roy has contributed to that area as well. So that would be illustrated in the case that I'm going to bring up. But before I do that, maybe we could, since it's a small group, we could take a minute and introduce each other so that we all know who we are. So I'll go around in the way I see on my screen, and maybe you can say a sentence about yourself and what makes you interested in this group and so on. So Kimberly.
Hello. So I'm the nurse prescriber at the Edinburgh Center. And as far as this group, it's been absolutely amazing. The information that's provided, the collaboration, just love it. So I can't say thank you enough.
Ananya.
Hi, my name is Ananya. I am the program coordinator for MAPNET and a clinical research assistant. Very interested in the topic, but cannot fully contribute, I'd say, but happy to be here and excited and very nice to meet everyone.
Nice to meet you.
Pega?
Hi, my name is Pega. I'm a psychiatrist and I work under Dr. Keshavan's team, and really nice to meet you.
Likewise.
Thank you.
Max?
Hi, I'm Max. I'm a psychiatrist in Fall River. I do inpatient work at a DMH community mental health center. And then I do a MAPNET CSC program too. And been doing that for the first part for like the last 6 years.
Wonderful.
It's wonderful, yeah. It's a little bit of my own trajectory too.
Lola?
Hi, I'm Lola. I'm one of the coordinators for MHTTC, and I'm also a clinical research coordinator on some of Dr. Keshavan's studies, so it's nice to meet everyone.
Great.
Nice to meet you.
Veronica? Maybe we'll go to the next one. Catherine?
I'm Catherine. I'm a child adolescent psychiatrist at the Utah State Hospital.
Wonderful. Okay.
Right.
Welcome. Lynn?
Yeah, hi.
Hi.
Roy.
Hi.
I don't think we've ever met. I'm director of a first episode clinic at Cambridge Health Alliance, and I've done research on schizophrenia for God knows how many years, 45 maybe. You know, doing much more clinical work over the past decade. So good to meet you.
Likewise, I think we used to probably send articles to you ages ago.
Yes, I edit psychiatry research.
Yeah.
Yeah, so Veronica, if you're able to say something about yourself, that'll be good. If not, we can get started. Okay, all right. So Roy, I'm going to present a case.
Okay.
And you know, that might illustrate some of the key issues, and then we can discuss what we know and also see what other people have to bring up on that topic. So let me see if I can share it. So let me, I was hoping to bring it up as a slideshow mode.
I had like a, you know, like a small case, but yours sounds good.
Yeah, so let's start with mine for now.
Okay. Yeah.
And see how it goes.
Yeah.
Yeah, can people see it now?
Yeah. Yeah.
Okay. So I'm myself kind of blocked from visualizing my own writings here, but I can say that.
You want me to read it out or?
No, I think it should be fine now. So this is a young lady, actually, I saw in Pittsburgh. So it's stuck in my memory. Yeah. So this young lady recently, you know, under treatment by our clinic, the STEP clinic. She had been diagnosed with schizophrenia when she was 22. She's now 28 years old, single, unemployed, receiving social security support, living with her 3 young children, all below 5 years of age. She had been regularly attending our partial hospital program for the previous 2 months. She had been stable till about 3 months ago when she had been briefly hospitalized for a psychosis relapse after a breakup with her boyfriend. Her previous medications that she had been very compliant with were clozapine, 600 milligrams a day, amitriptyline, 75 at night, lithium carbonate, 300 3 times a day. And they were all continued during the hospitalization. And she was also added perfenazine at night, 32 milligrams, that's Trilofon, benztropine, cogentin, 1 milligram twice a day, and clonazepam, 1 milligram twice a day. So this is the story. So people can comment on her medications, you know, if you want to think through this right now.
That's atrocious.
Atrocious, okay. What would you change, Max, and how would you do it?
So I think it lacks an overall cohesive strategy. I think that having a clozapine level would be helpful, but I can see already there's just a huge anticholinergic burden. Yeah. There's no way I would have any Trilofon on for anything. The benztropine I would kick to the curb, and the clonazepam. I've personally found that lorazepam is a better benzodiazepine, is like a slower onset, it's less addictive, and then the last piece is I don't see any propranolol, and I am certain that person needs propranolol.
Interesting.
I was just thinking of what you said, Max, and I was just adding it up. If all of them were added because of this exacerbation in the hospital, so clozapine, if we simply took, you know, those online calculators for anticholinergic burden, and many of them are not great for dosing. You know, in other words, 300 milligrams a day is considered the same as 300 a day or 100. For clozapine, you'll get a score of 3, which is the top score in the calculator based on the original ACB article written from Indiana. And then if you got amitriptyline as an antidepressant or to help with hypersalivation, she's got another 3. So she's got a cumulative 6. Lithium would be close to 0, for anticholinergic burden. Perfenazine, I don't know if it's a 1 or 2. Let's just give it a 1. So we're at 7. Benztropine, again, dose doesn't matter in this particular calculator. You have 3 more. So you're at 10. I think Klonopin 0, like lithium. Typically for mental status changes, all you need to be, at least in the elderly. Now, she's a young, early stage illness person. Beyond 3 to 4 matters. Beyond 6 becomes very serious, and in the elderly where this has been looked at quite a bit, the anticholinergic burden, you lose quite a few, mini mental status points for every unit increase in the ACB score. So just looking at this, even without eyeballing her, she's at an anticholinergic burden of somewhere between 9 and 10.
Wow. It's amazing how quickly you were able to put together the quantitative score without even looking at the calculator. But for the benefit of this group, and after this case discussion, I'd like you to share that calculator.
Yeah, absolutely.
Yeah. Okay. So let's go to the next part of what happened. So one day, Mary did not show up for her regular clinic appointment. And this was unusual for Mary. So the case manager called and there was no response. By the afternoon, neighbors were concerned because the children were crying loudly inside the house and Mary was not answering the door. Police were called and they entered the house to find that she had been deep asleep. When she woke up, she was totally puzzled. She admitted to having been very groggy and said she may not have taken the morning medicine again because she forgot. So this exactly would have been predicted by what Max said. And what you said, Roy. She got a complete overdose of the anticholinergic burden, which wiped out her recent memory and immediate memory. So, which is why she kind of not only took her medicine, but she took double doses of that because she forgot that she had taken the medicine in the morning when she first got up, and she took the medicine again and went into a kind of a prolonged state of deep sleep, which is what led to the situation.
And this is just a 28-year-old, right?
Yeah.
So you can imagine if we were giving this to someone in their...
That's a good question. So does the calculator incorporate age factor in it?
Yeah, I don't think, there's a group in Australia. She's from the States, but, I think has migrated or works in Australia, blocking on her name. And she said they've tried to look at the usual confounds, age, and medicines used outside of psychiatry that also have anticholinergic burden that we sometimes don't add up. But she said, by the time you get to a lot of the usual anticholinergic confounds, you'll have to sort of have like an amazing proprietary algorithm to get a reasonably good accurate count. But I think the basic ACB calculator, which I can share with you, if my computer has been acting up since last week, and the guy is going to come and swap it out. He said it's running at 1/3 the speed. It should. And so if I don't...
If you email it to me,
I will, and just distribute it to the group. Yeah, I'll do that.
Yeah. So basically that summarizes this case. So that's the lesson. And, I think Roy wrote a very nice, thoughtful paper, which she shared with all of you. Less is more. And without knowing that paper, I came up with a commentary in schizophrenia research the same year or the following year. Less is more, or something to that effect. What we said is that pharmacological subtraction is as effective as pharmacological addition, or more effective in some ways. And we looked at that in our data. Shaunik and I, as you remember, Roy, from Pittsburgh, we started that study of cognitive remediation, which we continued in Boston. And then we combined the data sets and looked at the relationship between anticholinergicity and various parameters, cognition, and memory and so on. And of course, not surprisingly, like many people have found, we did find a very strong relationship between memory and the anticholinergic load. So the anticholinergicity load was computed using a plasma level, using Bruce Pollock's lab. So Bruce is on some of our papers. And one of the findings there actually shocked me. And that's what I'll show you next slide. This is, we had not even imagined that we would see this. We had imaging data on these patients. And we looked at gray matter density and we correlated that with anticholinergicity levels. And we found a fairly striking relationship between the more gray matter loss in these first episode psychosis patients and the level of anticholinergicity that they had in their plasma. But mind you, the Bruce Pollock's measure of anticholinergicity, in vivo anticholinergicity, does not just reflect the overall medication effect. It also reflects an in vivo property of anticholinergicity in that individual based on his or her genetic propensity, his or her biology, so to speak. So it may be that the less acetylcholine that is flowing in our system in the brain, the more likely there is to have gray matter loss, which may be consistent with what we see in the early stages of mild cognitive impairment and Alzheimer's disease, where the first neurotransmitter to go is a Stanley. Roy, you have any comments on this?
Yeah, I think if we think of anticholinergicity, and if these procholinergic drug, xanomeline, trospium, which I guess is sitting in front of the FDA as perhaps the first non-classic dopamine modulating drug that may come to market if approved by the FDA. Finally, this old cholinergic hypothesis of schizophrenia is remaking its appearance, after decades and decades of sort of thought on this. And, there's this group in Oxford. Some of them are part of the Cochrane group, some are not. And they're sort of looking very closely at a lot of the anticholinergic burden in schizophrenia and its impact with all the cognitive domains. And as you pointed out, if we accept that maybe many of the people with schizophrenia eventually go on to have cognitive decline, would it be faster than a birth cohort of the same age group, or even faster than a, say, major depression birth cohort, or even a bipolar birth cohort? It's hard to say, because those kinds of things have not been done. But are we putting them at risk for, I won't call it dementia praecox, but are we putting them at risk for dementia?
You get really uneasy
because
the current prescribing pattern.
Did someone say something?
I was just wondering, like, how do you feel like the current prescribing practice, just in practice right now, is to lean so heavily on these medications? You will see people come in on 3 or 4 hydroxyzine, benzocaine, diphenhydramine.
Yeah, exactly.
And people use them as if they are some safe alternative for anxiety medications. And if the cognitive impairment and all that precedes the onset of the psychosis, it seems like we're spending coin, like the most important coin. If the cognition is what determines prognosis and everything like that, to do anything to undermine that early on seems like something that is kind of like should be addressed.
So, some of my things were literally addressing that. A couple of the cases I was going to show to you, but they're very basic. I can share the screen, but maybe easier just to keep having this discussion. Or what are your thoughts? Do you want me to share a couple of things? I only pulled up 2 or 3 slides, more case-like, to address this very point you brought up.
Yeah, go
like
ahead,
in
Roy.
practice.
Yeah.
Yeah?
Yeah.
Is it okay if I share?
Yes.
Let's see. Let me see if I can. So might take a second. This is like a slow computer. Are you able to see it?
Yes.
So, looking at this, you can see a patient who comes in stable. Do we really want to continue the EPS med, and for how long? So this is the key, right? And so when deep prescription comes in, are we going to, if the combination is what is allowing the, say, potent D2 drug to maintain mental stability and to maintain people back in the community, do we want to rock that boat? And so literally, not able to, yeah. I mean, this, so I'm not going to go, let me see if I can go back one. This story, and we don't want this story, so we use EPS drugs to help us with any antipsychotic that tends to cause this, right? And then this is from med school or even before med school. And then it continues to do well. Why should we rock the boat? After all, what might be the arguments for and against? So, if these are going to be used, quote unquote, for life, and there's nothing else that comes along that's as efficacious for that individual, should we continue it for life? Or should we think people adapt to these and maybe there's no requirement for some people? And so this is where our QI projects began 6-7 years ago. And this is just a large, huge database study published in the JAMA Internal Medicine on a bunch of drugs, mostly with anticholinergic side effects and the risk for dementia. It's not a cause-effect study, but you can look at the cases they have. And I just took one drug type that are anti-Parkinsonian drugs, and we can put in, benztropine and trihexyphenidyl there. And in Britain, there's more anticholinergics that are used in other countries too. But if that one line where the exposure is more than 1,000, days worth of exposure, and the unadjusted odds ratio for the risk of developing dementia, these are typically follow-ups for between 1 and 11 years in this population. And if it's more than twice the odds, and even if you adjust it for everything else, other meds, and it's still at 1.61, maybe at some point we have to think about rocking the boat, because the side effects, I think, also, not just the annoying side effects of a dry mouth, constipation in the case of, drugs that cause GI hypomotility like clozapine, possibly olanzapine. This could be adding a lot of issues to people who are young, let alone in their 50s and 60s. And so those are the reasons why we did the deep prescription studies. This is just part of a larger thing I share.
Roy, if I may ask, this may be an anomaly of the statistics and the numbers. The odds ratio seems to be higher for the use of 91 to 365 days.
I know.
Compared to
and if you look at the numbers of controls, I think even with such a whopping GP database study in Britain, the actual numbers begin to fall off. And so how tight is that and how precise is that estimate is the problem, I think. The confidence intervals seem fairly tight, right? But there's a lot more in that paper. I just took out this just to make a point that in addition to like the biological finding of gray matter loss that you found, and here, and any more that people now with schizophrenia in integrated systems of healthcare, where hypertension, diabetes, lipids, everything is being concentrated on, are beginning to live maybe not making up for the 25 years of life lost, but maybe making up 10. And just in our practice here in Pittsburgh, any more people are 60s and 70s when something happens, medical mostly. I just wonder if we can decrease this burden. In our small quality improvement projects we've done in our clinic, just in the academic clinic where we have a pharmacist embedded, we were able to discontinue 2 out of 3 patients, either taper or completely stop, or 3 out of 4 patients. In a busy clinic, we went deliberately to a place that doesn't have an embedded clinic. It's Montauk. You might remember this, Keshavan. It's now part of our network. And they are like 15-minute med check clinics. General psychiatry, they don't have specialty just for schizophrenia. And they were only able to discontinue with a lot of education, building in smart phrases into the electronic records. We even developed a scale, we call it the Pittsburgh Anticholinergic scale for self-report. At best, we could get to 30%, because they're very, very busy and this is not a priority for them. And about 10%, we had to go back on the meds. Because this is, like biological sensitivity, even if they were taking benztropine and the antipsychotic for 5 years, you still needed it. And on examination, they didn't have any EPS. So we advise typically not to meddle with it when people are clinically not quite stable. And not to meddle with it at least for 6 months. The WHO recommended way back in 1990, start looking at this after 3 months of use. But in 2024, there's tons of people still taking it just with refills, and no one's doing, rigidity, tremors, not no one, but a minority do it. Mostly in community mental health practice, a lot of people are not doing that and not thinking whether you truly need your benztropine or trihexyphenidyl. And anymore, as you pointed out, Max, it's hydroxyzine that's taken off.
I've seen
an
so many
alternative
people
to the
coming-
benzos. Yeah.
Frank Parkinsonism, signs of anticholinergic toxicity, and their team will tell me they've never been better in their entire life. I think there's some element of us just not being very good at identifying psychopathology anymore.
Yeah.
To know what the difference between like this really flatness and this tremulous kind of like vague emptiness that you see a lot that can precede an admission by a long time. And those are the ones I see on really high anticholinergic burdens. Their pulse will be 110 and they answer reflexively to everything. But we don't even have the vocabulary to talk about things like a reflexive answer to your questions. So we just call them stable.
Yeah. And, so it's a classic differential diagnosis, right, for these persistent negative symptoms. Are they just demoralized? Are they, are they having a depressive episode? Or are they just Parkinsonized, and are we missing the boat on that? And so I think, as we've all trained in this, it's worthwhile, I think, even in people who are stable and who are just coming back and forth, to get into that discussion. When is it the right time to deprescribe an anticholinergic and when is it not? And how do you prep people? So we even created like a little patient handout that we'd like to refine a little more. We have a scale that we use. We've built it into our Epic. We use Epic here in our outpatient electronic record system. And we haven't built the ACB calculator. I'm sure, the group that has the copyright on it, it's an institute within the Indiana University Med School. But they'd probably allow us to use it, in clinical practice. It's a reasonable one. The ACB calculator itself was developed by, I think, maybe a software programmer out of Britain with a family practice doc. So, of course, it has a lot of meds that we don't have in the states. But it's fairly good. For the common ones, it's there. The latest, antipsychotic may or may not be there. Maybe the last 2 or 3. But most of the others you can do like I was doing for you when Dr. Keshavan presented the case. I was just adding it up in my head, simply because we've done this for a long time. But I think it's really worth considering. If we're seeing people, it's almost like a wellness check, but if we could build in an anticholinergic deep prescription as part of that wellness check, be really worth it, I think. Say you had a score of 7, you'll be down to 4. And what we see, the obvious changes are dry mouth. 1 or 2 of the parents and caregivers have told me, oh my God, the dentition, even the dentist has noticed an improvement because, they're not sucking candy and all sorts of, chewing gum and on, or even just taking a lot of sugary pop and soda. So you can just imagine the effects that go from there using far few Miralax, Senna, or even the prescribed laxatives. And with clozapine, if you can decrease the clozapine-associated constipation, that'd be huge. And certainly this would contribute. So there's just multiple effects, let alone the cognition things, that we've measured in one of our studies. It was a QI project. And we just used the memory impairment screen. I like that because I think it taps into certain elements of anticholinergic burden type memory problems. So we use that. Easy to use. We got permission from, was it NYU or I forget who, Dr. Bushki. I think he's retired now, neurologist. He was developing something for an early screen of Alzheimer's, late 80s, early 90s. And it was called the selective reminding test. So based on that, he came up with the MIS, and others after him have refined it. We just find it like very easy to use. It's like a word list. And, you show these 4 or 5 categories, you distract them like we do in many of the other word list sort of memory tests. And then you have them just spontaneously tell you, and then for each cue, they don't get a high score. And then, very quickly you can say on the cognitive screen whether, you need to look at it more carefully. And in that, we found people were improving in a deep prescription that occurred over 2 to 6 months. Of course, it wasn't a randomized study. We were just doing it as a QI project. So it's confounded by that kind of group like us who are particularly interested in this. But I imagine even if the results came out a little less strong, and if we were to replicate it, something really worth trying,
So Roy, since you mentioned constipation, I have currently a patient want to pick your brain on, and maybe others' brain. He's on clozapine, beginning to show improvement. Young man, 26-year-old, early course psychosis, and we did not respond to 2 other antipsychotics, and he's beginning to respond to clozapine. But his constipation has been a challenge to address. So we tried, Docosate, and then Senna, and then most recently Linzess. None of them have worked. So how would you handle this?
Yeah, so it's a tough one. I think what we've gone for is usually we find Colace, Docusate very mixed. An occasional clozapine patient that I have will like it, and I've used it forever. Mostly we use a combination of Senna and Miralax first. And sometimes we go to full doses of Senna. So, I think we'll go to twice a day of Senna and twice a day of Miralax. And the instruction we give is stop using the stimulant, which is Senna, when you start having loose stools before you go to diarrhea. So that's something We do. And yeah, we do. I've used lubiprostone, Max, and I've had every now and then I run into copay issues depending on the insurance carrier versus not. And with lubiprostone, definitely we've had some benefit. I think like the original case series out of California State Hospital System, I think, Jonathan Meyer and gang did it. And so they had like fairly good success, so much so that they finally had to use PRNs of the usual. So, but we find the other thing that doesn't work in clozapine-induced constipation and may actually worsen it are the bulk laxatives. This because it's gut hypomotility. From esophagus down to the end of the colon. I mean, the New Zealand group, what's her name? Every Taylor, I guess, right? Yeah. So she is done a lot of work in this. And every which way, there seems to be dysmotility starting way up in the GI tract. She says it's not just lower GI. We need to be bothered even with the upper GI and stomach and everything in between. And the just segments of hypomotility when she does these wired capsule kind of hypomotility studies. So the grandmom's adage of, eat high fiber, use fiber laxatives, not generally a good idea with clozapine. So we tend to use Senna, preferably even over Docusate, and to full doses. We use it even BID, and we tell them, or their caregiver, if they're not sort of, if they're a little more concrete about this or just can't handle the information, as Max was pointing out, many of our patients on clozapine can't. And then we sort of tell them, then add Miralax. Or sometimes it's the other way around. We start with Miralax and then add Senna, and sometimes we use the combination together. And in 2 or 3 patients, I've got lubiprostone on top of it.
I see.
It's because you have to manage it very aggressively unless you want a situation with the rare situation, luckily, but still happens, of bowel obstruction, pseudo obstruction, and the ileus, And so in these residential places where they live, I often take the Stahl and Meyer book on clozapine and take out where it's an emergency. You can't mess around and say, we'll call the doc on Monday morning. Send them to the ER or urgent care if they show these signs of paralytic ileus. If there's any situation where they have LPNs or any nursing, caregiver attached to a residential facility where clozapine patients are being managed, or if there are family members looking after them, I make sure they understand paralytic ileus first, signs and symptoms. I tell them this is a medical emergency.
Yeah.
You cannot wait. Do not wait till Monday morning. This is like, go. Anything less than that, constipation. And then we've taken some of the inpatient logs of these longer stay units, and I did a QI project. I can send that too if you're interested. It got accepted into a nursing journal. It's where we came up with a log, and we do this as part of our treatment teams in this long-acting facility I go to. Half our patients are on clozapine there, so we have to be on top of our game there, where we monitor bowel logs. And we take this definition, the Rome criteria for constipation that was used more for opioids, but it seems to apply, to clozapine reasonably well. And all the nurses have been trained to ask that in a private setting, because otherwise some of the nurses were asking in the Medline. That's not a good idea for, people who are sensitive and want privacy. So we've just created like a bowel log, and I can share that with you.
That would be helpful.
If the intervention was done, did it work? Did it not work? Did we take the next step? So I think with the moment clozapine induced or associated constipation is at 3 or 4 days with no bowel movement, that would be cause for concern already. So, you
Oh, I
know,
see.
some people would say, hey, doc, I didn't go the whole week. I said, really? Are you sure? Yeah, that would concern me, you know.
Okay. Yeah.
So I would just use the definition 3 days or more, which is like the old GI definition.
So what would you do if it is 3 days or more?
3 days or more, we would do combination laxatives. We would use a stimulant along with Miralax, Senna plus this. If the two didn't work for another 3 days, we would add lubiprostone as a secretagogue and go after it, you know. And if that, and then we would start telling anyone and everyone who could listen to us, here's what you need to watch for IDS. If this happens, don't even bother trying to reach me. Just go to an ER.
Okay, that's very helpful. Thank you.
Yeah. So we would manage it super, because we don't want that 0.4% of mortality.
Yeah.
You know, that little, remember the Dear Doctor letter that came out from the FDA about 3 or 4 years ago, around the time the pandemic was beginning, or just before. So that's when I thought, like, we had a turnover of nursing staff. I thought this is going to be bad. We have 16 long-term beds in the step-down place. It's an adult mental health residential facility. And Lori Albertusky, who's, you know, my partner in crime there, she's the nurse manager. She was very much into nursing education. So we just developed this QI. I'll send you that paper with all the supplemental thing, because they're very practical.
Yeah.
Including the tables, the patient handouts, the nursing education, which all of us, you know, as people who prescribe, should just be giving it out like candy and then explaining these handouts and tools. It's the only way we
I think
can
the book
maintain
by
some of
Robert
the-
Lightman is also very useful. You may have seen that.
Sorry, I missed that last part.
The book by Robert Lightman.
Oh, yeah, that's good.
On clozapine is also very
the
useful.
Meyer and Stahl book is excellent. The
Yeah, it
clozapine
is
handbook.
wonderful. Yeah.
Really nice, yeah.
Yeah. Okay, great. Do other people have any thoughts or questions about similar issues in your practice?
I saw something in the chat from Max about tachycardia, right?
Yeah, when you're starting clozapine, it's like pretty, almost not ubiquitous, but very, very common. And it's something I've been treating as part of just kind of a general approach to lower the amount of distress in the situation when we're doing clozapine initiation. Is that how, and I think it might be, personally, I think it might be one of the reasons people do have that inflammatory reaction a lot, like just letting heart rates kind of get out of control and stay high, anxiety stay high. Do you find that when you treat a lot of patients with clozapine, do you deliberately treat their heart rates? And do you have a high incidence of people with like inflammatory conditions like myocarditis or pleuritis or whatever it might be, pneumonitis?
Yeah, so this is a very, very practical and important point you brought up, you know, Max. In the early days, you know, because we were part of Study 30, the original sort of study, the Kane et al. Study, and we did ours at Mayview State Hospital that's now closed. After a 150-year run, they closed it. So in this county and the surrounding 5 counties, we don't even have a state hospital. So you can just imagine what that has done overall to the continuity of care around here. But anyway, we didn't treat it as rigorously or pay as much attention to it. We just accepted that as an anticholinergic side effect. And we thought, okay, we're familiar with propranolol, you know, for akathisia. And if there's no contraindication, but as you know, what's happened, of course, with these non-specific beta blockers is a lot of our guys smoke, even on clozapine, even though it's, you know, somewhat less, and some people even quit with clozapine, even without any counseling. But nonetheless, you know, COPD, asthma, exacerbations of COPD, this is kind of nonstop. And what will beta blockers do when they're using these, beta inhalers? So this is one issue. And then many of our people become diabetic, and, these are not absolute contraindications, but we have to be a bit vigilant, right, about using some of these non-specific beta blockers. So about 7-8 years into clozapine's launch, when I was just doing the clinic, and Keshavan was still here in Pittsburgh, I started using propranolol because I'd been so used to it, using it not like Dr. Manchanda did in Ontario, super high doses. He was using it almost for treatment refractory psychosis and stuff. But we were just using normal 60, 80, up to 120 milligram equivalents and watching how far the heart rate would dip. And if they went to 60, starting out at 110, 120, we'd worry a little bit. But if they were just dropping into like a 60 to 100 range, we were happier. And every now and then, for exactly the reasons you mentioned, these inflammatory conditions between the respiratory conditions, the heart condition, the pericardial stuff, and sometimes whether clozapine's causing that, it was a little bit of a mess trying to disentangle the whole situation in our heads. But I have to say, I haven't used it as some of my younger colleagues. They're much more comfortable starting people the moment people hit 110, 120, and don't seem to come down. I used to talk more to cardiologists and wonder, and they would say, any symptomatic stuff? I said, no, but this is a group that smokes a lot, is sedentary, is obese, would have all sorts of cardiometabolic issues coming on. And then they said, well, why don't you just use it and see, and what kinds of doses? And they would just laugh at my low dose use, because I think their scope of practice is very different, right, as cardiologists. And so I began to have more courage and started using it in the 90s. I still use it, but not as frequently as some of my younger colleagues. They love to get it below 100, and they worry about, eventually things like ejection fraction and stuff. And we haven't had huge issues. Some people use the more selective beta blockers, and that seems to work too. And, that old myth about beta blockers causing depression, and would you induce a depressive episode and would someone take their life in the middle of a melancholic episode? I really haven't seen that in practice. And I think the literature has kind of been somewhat buried on that over the years. But we do pay attention to tachycardia a tad more than we did. And if you had panic type symptoms on top of it, or OCD type symptoms that could lead to anxiety, or any stress that drives stress-induced inflammation, then why not calm them down a little bit? Why not bring the heart rate down a little bit? And maybe,
there's one other angle to this.
Yeah.
Right. That the same patient that I talked about for constipation.
Yeah.
He had another issue. His heart rate was generally like 100, between 100 and 110.
Yeah.
So I started getting his CRP levels. And the CRP levels kept creeping up to, it went up to 21 at one point.
Oh, wow. Okay.
I got a troponin, which was normal, within normal limits. So I backed down on the dose of clozapine, and the CRP dramatically came down to 5 or 4 actually.
Yeah.
And so I'm less worried about myocarditis, but at this time, that's something we have to keep in mind and worry about.
No, I agree, and I think it's a good way that you did the troponin. I had the 63-year-old lady this past weekend. Doctor, you remember Chuck? He worked under you, Chuck Khan. He wrote some papers with you even. So he's like the medical director at McKeesport now. And so he sent me a patient to the step down. She's 63, and her anticholinergic burden, by the way, is 9. Because he's giving her hydroxyzine, and I managed to cut that out. And he was, giving her oxybutynin for an overactive bladder. That gave her another 3 points. And it's the usual story. Most of you know this in practice. And I managed to cut that out, but she developed, as you would, I'm sure you've had this experience, pulmonary embolism, clozapine, and oh my God. And also at the same time, 4.5 months into clozapine, everyone who knows her for the last 12 years says, this is the best she's looked. So, you're stuck between a rock and a hard place, the usual.
Psychiatrically,
Yeah. clozapine story. So I'm calling the consultation liaison psychiatrist on the weekend, is a resident who actually works with me. Luckily, he's moonlighting there. And I tell him, please don't stop the clozapine. No, but now she has tachycardia. She's running at 120, 126. She's 63 and she's got COPD. She even at Pathways, she's, hey, Dr. I'm going to miss my smoke break. When are you going to finish? This is the conversation. I'm trying to get her to quit. Instead, she's trying to run for the smoke break. This is sort of the story, unfortunately. And so they put her on beta blockers, and I haven't logged on this morning onto Cerner. We use Cerner for our inpatients. They'll switch to Epic in the next 2-3 years. But so I will switch and see what's happening with the beta blockers. Has she actually, calmed down? Pulse ox, which had dropped into like just at room air, was down to like 86. When they called me from the nursing station, and I just shipped her off to St. Margaret's. And I thought it might have been pneumonia because she was getting short of breath. She was sweaty, but they saw pulmonary emboli, both sides.
Wow.
And thank God, she was in the hospital, admitted, and they're taking care of her, and the pulse ox is back, but they're giving her oxygen into the 90s. And she'll come back with propranolol. But I did manage to, and I'm having insurance issues with Myrbetriq, because I want that instead of the oxybutynin, just because she's got confused also in between with all this anticholinergic burden.
Is that the sure reason that she's having incontinence? Because I found a lot of times there's a incontinence that you get with alpha blockade and with clozapine in particular. Like it loosens up that sphincter, and sometimes you can like counter that with an alpha blocker or not pseudoephedrine, like an alpha agonist, stuff like that. Because it's not always just bladder irritability.
Yeah. I agree. It's sometimes just bladder capacity even, right? But I don't know what you have found helpful non-pharmacologically. I find men are completely unwilling to do anything vaguely related to Kegel exercises. Some women are more willing, especially if they've gone through childbirth a couple of times, they've been through maternity hospitals, the ones where the nurses would try and teach increasing the bladder capacity using Kegel exercises. But sometimes with her, we ended up with such severe incontinence. They were throwing away the sheets and mattresses when she first came from McKeesport Hospital, which is the community hospital here. And, and then with the oxybutynin, I even had to raise the dose from 5 to 10. And she became a little more confused. And that's when
highly anticholinergic drug as well.
Oh my gosh, so with each of those kinds of drugs, you're adding 3 points. I said, clozapine's 3, olanzapine's 3, quetiapine's 3, benztropine trihexyphenidyl is 3, amitriptyline is 3, visceral hydroxyzine is 3. So you can just add up. And oxybutynin, on that whole class of drugs, till we had Myrbetriq, which was the first alternative to the anticholinergics, were all anticholinergics. All of them are 3. Some of them may not cross the blood-brain barrier, like trospium. It's been added to the xanomeline. Could be a drug,
Robenal.
So
Robenal.
I haven't used that
for drooling. It's like doesn't cross blood-brain barrier.
Yeah.
You can't get topicals. They won't do topicals.
Yeah.
Like
as a topical, No, that would be a good choice, I think. We used like the nasal sprays, or the atropine sprays, but used off-label under the tongue. I don't know what you
towards your ACB. Do you count your glycopyrrolate towards your ACB? It's like a 3, but it doesn't cross the blood-brain barrier. Blood-brain barrier.
And I think it was used a little more in the ID population, wasn't it? The
Parkinson's people.
Yeah, Parkinson's too. And one of the big, I don't know if it's our instruction or, and I saw a patient of mine in this long-term place about 5 years ago, where I go 1 day a week there. And I saw them using the atropine eye drops under.
That's what we
And
do.
I just happened to be at the nursing station. And I realized what the nurse did. She took the eye drops and put one drop. It was full of saliva. And then she put one drop on the other side of the filter. And I said, but how do we know this is even soaking through the saliva to get where it needs to get, even if it's topical? So after that, I talked to Rob Coates and I said, how about making a video on this? Because my pharmacist, she's unwilling to sort of be, videotaped, because we use thick pads of tissue paper and literally, or sometimes like napkins almost, and dry it before we put the drop of the ipratropium or the atropine, the nasal spray or the drops. Then, of course, you get the real bad taste in your mouth, but it actually works.
Interesting.
Otherwise,
this is a fascinating discussion. We have a couple of minutes left.
Okay, sorry, I lost track of
This
time.
is wonderful, and I would appreciate you sending that that calculator.
I will. I'll send the link to that, and even some of the bowel movement logs if you want to use it. The Pittsburgh Anticholinergic scale that isn't as nicely and well psychometrically developed, but I'll send those as practical tools you could use.
Yeah, but let me use the remaining 2 minutes to ask others if they have any questions.
Should I be looking at the chat? I haven't sort of, opened up the chat. I see there's like 7 items.
Do you deliberately treat tachycardia when starting? That's Max's question.
Yeah, just some stuff I put in.
Yeah, a little like, the muscular male who needs to be on Cogentin before you give them like a Haldol shot or something. No, I don't really, to be honest. I haven't. Personally, I haven't.
Any other questions from, Lynn, you have any thoughts, questions? I'm sure you see a lot of these things. You're muted.
Yes. Okay. Yeah, I had a number of points I wanted to make. Let me just try to be brief. One is that I see that psychiatrists are using Cogentin at high doses, much more than I had always been trained to use, and using it prophylactically, which I thought we shouldn't be doing. We should really treat the symptoms. And I wonder if also Kesh's case, so to go back, Cogentin, my gosh, I would just give 0.5 milligrams to see if that helped.
Yeah.
And to give 1 milligram twice a day is really overkill. And, that would cut down on the cholinergic load right there. But Kesh's patient was really concerning to me for many reasons. One is that why did she need Cogentin in the first place? Could it be that she was treated for lithium tremors?
No, I think she was started on that as a prophylactic because she was also treated with perfenazine.
Oh, right. But perfenazine is not a high Parkinsonian medication. I have many.
But it's still classed under typicals. It's a typical.
It's a typical, but it doesn't mean, if she were on Prolixin, I would say, that's going to cause Parkinsonian effects. But, I would have seen what it would have done first before I just gave prophylactic Cogentin. That's one thing. But also this poor woman, from a psychosocial standpoint, let's forget the pharmacology a bit, but she is most likely misusing her medications, not taking them properly. This is a single mother of 3 small children. Does she have supports? I would have a nurse go in there and dole out the medication. That's what we do with most of our patients. So they're not responsible. So, there's a whole bunch of things. There's child welfare involved with children.
Yeah.
Yeah, so anyway, those are my thoughts.
Yeah, those are very important. The
Yeah.
psychosocial
I think-
angle should always be considered.
And what I find, I think, is like anymore, I think in short-term hospital, especially recently, Lynn, what I find myself doing in the longer-term stays is really de-prescribing a lot of the meds,
Yeah,
optimizing it. And we have, we don't have a 5-day length of stay where I go on Thursdays for this longer stay. They're often there for 6 months, 9 months. And it's almost as if you feel, you can optimize their meds, even do a clozapine trial if they're not, and if they're on too much polypharmacy. So we have those options. But
yeah,
otherwise, in a fragmented care system, where there's a lot of staff turnover, huge caseloads, this seems so much harder to achieve ideal practice is what I find,
yeah. But you also have to remember that patients, if they take their medicine consistently once a day, that's all you can really expect. And so to give
Yeah.
lithium 3 times a day
Yeah,
when
yeah.
you really
I
only
agree.
need it at night, and the same with the clozapine. I think you'd get much better compliance. So, yeah.
All excellent points. Thank you all for staying a little extra time. This was very,
Yeah.
very helpful. And this has been recorded and will be placed in the MAPNET website. So we can keep going back to it as we.
Yeah, thank
But
you,
Roy,
Roy.
thank
Thank
you so
you,
much,
thank
Roy.
A lot
This was
from all the things you said, for sure.
very
Thank you.
enlightening.
And I'll send you all the stuff,
Yeah.
and you can put it onto the website or whatever you feel comfortable. I'll send you. There'll be quite a few attachments,
That's wonderful.
Okay.
And we definitely would like to bring you back to this
Okay.
discussion sometime.
Thanks.
Thanks again,
Great
everyone.
meeting all of you. Very nice.